Before we move on to gas exchange, I just want to talk a little bit about capacities of the lung and just a few measures that we do with just dealing with respiratory volume and gas exchange in and out of the lungs. Normally, respiration, we talk about one ventilatory cycle being an inspiration and an expiration. On average, the resting breathing rate's about 12 beats per minute. That is adult average. Obviously, children, those people that are smaller, tend to have a higher breathing rate because their volume per breath tends to be a little bit lower. That minute ventilation then means that how much in a minute is about 6 liters a minute. When we start talking about 12 breaths, about 500 mils each, somewhere around there. There is ways to measure this. If we were still having lab, we would do the spirometer, which is a little thing that you can take an inhalation in and then blow out on. And this is a way to measure lung volumes. There is those ones. There's ones that you are blowing air into water as well. So there's what are called dry and wet spirometers. But either one of these can measure actually your breathing volumes. So what I want to kind of point out on this one is just some of these different volumes that would be important. These are things I could ask when it comes to the test as to what is the particular volume and what is it signifying. So that normal breathing in and out is this tidal volume in the little yellow right here. That is that normal breath in and out. It's about 500 mils. The other thing to realize is because our lungs are not collapsible, there is a certain amount of volume that stays in there just because the airways are open. So if you think about it, if you breathe in 500 mils, there's about 150 mils that aren't actually reaching the alveoli. That's just taking up space inside the trachea, the bronchi, and other stuff like that. This is also part of the reason you can't go underwater and have a 20-foot tube and breathe up to the surface on it. You can't expand your lungs enough to move all that dead air in that volume in that tube. The inspiratory reserve volume, this is if you were to take a normal breath in, the amount of air that you could inhale in further, that volume of air, would be the inspiratory reserve volume. The expiratory reserve volume is after you take a normal breath in and do a normal exhalation. That's that little bit after you were say to go, and you went the rest of the way. That would be the expiratory reserve volume. A number that we don't really have the ability to kind of actually measure is the residual volume. This is the amount of air that is just in the lungs because they are open. That anatomical dead space that has to be filled by air because we do not have a collapsible breathing system. So the residual volume is about a little over a liter of air. So if we talk about our capacities, the inspiratory capacity is after you start taking a normal breath in, all that air you can actually breathe in. Inspiratory capacity is all the air you can breathe in with a normal breath plus the extra reserve volume. The functional residual capacity is the amount of air that would be a forced expiration plus adding in that residual volume. So again, this is a number we could actually measure. This one estimated because of residual volume. When we start talking about vital capacity, this is the total amount of air you can move in and out of your lungs. And then if you take that, add it to residual capacity, that gives you that overall total lung capacity. And like I said, there's ways to actually put all these into formulas and calculate this. But again, having a basic understanding of what these different capacities are easy questions to ask on a multiple choice. Should be easy ones to kind of answer as well. May have you do a drop and drag with something labeling some of these areas as well. Other things that we can kind of talk about here, like I said, that forced expiratory volume, inspire as much air as possible and blow it out as quickly. So again, it's how easy it is for you to expel air. Sometimes that's a measure that doctors are going to want to look at. The FEV percentage expelled in 1 second, how quickly you can get your air out. As you get older or with emphysema, it's much harder to blow air out, so that FEV1 will decrease in those type of people. Maximum voluntary ventilation, greatest amount of air that can be taken and expelled in a minute. So this is kind of almost hyperventilating. Like it says there, normally it's about 6 liters per minute at rest. You can get up as high as 30 liters per minute when you're actually trying to do this. And again, any issues with your respiratory system, some type of disorder, will cause these values to drop. And again, this is just a nice little way to kind of show you the capacities and what the definition of them are, as well as, the volumes and some of those definitions, as well as the capacities and what they're a combination of. And again, airflow getting in and out of the lungs, it's really that pressure gradient as well as resistance due to the opening in the airways, the ability of the chest wall to expand. So pressure gradient we generate by changing that pressure relative to atmospheric pressure. Again, the resistance is going to be things like bronchoconstriction. Bronchoconstriction is going to increase resistance, therefore decrease airflow into the lungs. So if resistance increases, airflow lessens. If it decreases, the airflow will increase. And again, we change that pressure by changing the volume of the lungs to create a slightly lower pressure versus atmospheric pressure. If you start using more forced inspiration, we can create bigger volumes and create a bigger pressure gradient, which means more air and a greater airflow because of that will be able to move. Again, resistance really has to deal with, like I said, bronchoconstriction, bronchodilation. If you have any issues with emphysema and loss of alveoli or collapse of alveoli, those are going to be issues that are going to increase resistance that you have to overcome to get the air to go in there. The other thing is as you get older, the elasticity of a lot of your tissues decreases. One of the things this can do is inhibit the ability of the chest wall to expand as much, and that is going to serve as a resistance as well. Collapsed alveoli, like I said, this a lot of times happen if you're not producing enough surfactant. Usually this is a condition with infants being born a little bit too early, this preemies, and they have this really kind of respiratory distress syndrome happening. Compliance is talking a little bit about the resistance of the chest wall. The easier it is for you to expand your chest, the greater your compliance. The less that is able to do that. So as elasticity decreases, or if you had a rib injury that hurt to take a breath in, you would have decreased compliance. Other things that can mess with that resistance, again, like I said, asthma, things that mess with the bronchial sizes, or fibrosis, things that don't let the lungs expand as well. So that scar tissue in the lungs could also decrease airflow. And again, if you have anything that's doing this, so if you have an asthma, a lot of times you'll see people that are sitting there kind of going, trying to suck more air, and they're doing a much more forced expiration and greater energy needs to try to get this. And sometimes these people can just become exhausted from just breathing alone because they're working so hard to try to pull that air in. So what we'll talk about next time is how the gases exchange, the physiology of that. Like I said, how things change with atmospheric pressure. I'll see you next time.